So good afternoon. I'm Matthew Moore. I am the president of SAGE, MCH SAGE, which is an organization that promotes maternal and child health knowledge and experience through events like this. Just before I introduce our speaker, I wanted to make one announcement about SAGE. We're having our annual Halloween bake sale, which is how we fund our seminars. And it's going to be on Halloween, which this year is on October 31st. And it's a Tuesday. So feel free to dress up if you want, but feel even more free to bake some of your favorite treats and donate them to be sold for our benefit. But if you really like to bake, I mean, even something store-bought, we really would appreciate your donations because it makes things like this possible. Also, on Halloween, stop by our tables in the lobby from 8 a.m. until 1 p.m. with a card or cash, and come get your snack on. Other than that, we don't have any other announcements, so you're welcome. Today, we have Katie Corvey, who is completing her DRPH in Maternal and Child Health Policy here in the Department of Healthcare Organization and Policy at the School of Public Health. Her primary research interest is insurance policy, and as a part of her dissertation, she's examining recent trends in private insurance coverage and their impact on affordability of care for children with special healthcare needs. She works collaboratively with Medicaid and All Kids here in Alabama, and she teaches undergraduate and graduate courses in the School of Public Health. She has been a familiar face around here for a while, so she's a great source of information.
You've been here too long.
Yeah, well, no, I mean, but thanks so much, Katie, for being here, and take it away.
All right. Well, I'd like to say thank you to Sage for letting me come and geek out for a little bit with you guys. This is kind of what I really am into, and so I appreciate the opportunity. And I have to say hi, Mom. She's listening in. So, all right. So, baby, when they asked me to put together a seminar on health reform, right, that's kind of a daunting task because all kinds of new information is coming at us every day. Nobody really knows what the heck is going on, right? So hopefully today we can kind of get a little bit of clarity about why we need health reform, what the Affordable Care Act does, and what have been some of the things that have been happening over the past 6 months or so in terms of reform efforts, right? But I would like it to be as conversational as possible. So at any point, ask questions, make comments, we can have dialogue, and that would be probably much better than just staring at me while I go through slides. So we have a framework, but we can deviate if that's more interesting. Why do we need health reform? Why don't we start there, right? What's the big deal? What is everybody talking about, right? So in the very shortest explanation possible, right? The United States has the highest healthcare spending in the world. Right? About 20% of our gross domestic product, which is a measure of our national economic productivity. We spend about a fifth of our GDP on healthcare, right? So what kinds of things are included in healthcare spending? Like that. Medications. What was that? Medications. I thought you said vacations, and I was like, maybe. All right, medications. Well done. What else? There's hundreds of things. Don't be afraid. Screenings. Yeah. All right. Hospital care, physician care, public health spending. Right. Lab work. Absolutely. All right. So for all of this money, the billions of dollars that we spend on our healthcare system, we only have mediocre health outcomes. So compared to other developed countries, we spend a lot more and we have kind of crummy outcomes for what we spend, right? So in terms of life expectancy, infant mortality, some other measures like that, right, we don't do so great compared to those with similar economies. But with that said, if you have something horrible like cancer, right, this is the place you want to be, right? So what are the implications of that, right? If we do really well on some of these really complicated diseases, new technologies, but we're not doing so great on some of these other measures, what is that kind of an indication of?
Good research efforts.
All right, so research and development. Thinking from a public health or an MCH lens, what are the implications of that? of a healthcare system that is focused on high technology, high cost interventions?
Well, we tend to be more focused on tertiary care instead of kind of primary care or preventative efforts.
Right, so we're focused more on tertiary care rather than preventative efforts. What about things like equity or fairness? Right, does everybody in the United States get the same access to quality health care? Not really, right? So for all this money we're spending, we have a lot of problems, right? So we spend a bunch of money, we have crummy outcomes, and we have a large number of uninsured, right? So even at the end of 2016, we still have 28 million Americans who are not covered by insurance, down from 44 million in 2013, right? So many of the provisions of the Affordable Care Act came into effect in 2014. And so we see the drop since then, but regardless, we are not near universal coverage. All right. So how are things done in the United States, right? We do things a little bit at a time, right? So historically, we've kind of taken this tack of incrementalism, and that's kind of how health reform efforts have gone so far, right? Very rarely do we get massive sweeping change, right? So here are some reasons why they're easier to reverse. It's kind of like experimenting. If we make little changes and see how it goes, not so scary. Politically, it's easier, right? As we've seen, anything done is very difficult politically. But that said, we've had some pretty sweeping changes over the past century or so, right? Beginning with the New Deal following the Great Depression. The Great Society, Medicare and Medicaid were introduced in the 1950s. CHIP, as in the 1990s, we'll talk a little bit more about CHIP, close to my heart in a little bit. And then the Affordable Care Act, right? So in recent memory, the largest overhaul of the health reform system that we've had. All right, so the Affordable Care Act. How many people are familiar with the Affordable Care Act or its provision? Yeah. All right, cool. Well, we'll sail a little bit through some of the major provisions just so you have an idea of what we're talking about. Right. So the Affordable Care Act had three principal goals, and you'll see they align pretty well with those major issues that we just talked about. So expanding insurance coverage, controlling healthcare cost growth, right? So we want to kind of bend that curve in spending and get more value for the money that we do spend on healthcare. I mean, we also want to have some incentives and programs in place that help improve the healthcare delivery system. Right? And Monica can tell you about that with her quality improvement research there. So when we're talking about insurance coverage, the mechanism to expand coverage, you've probably all heard about the individual mandate and the employer mandate. We'll go through these in a second. Medicaid expansion was a large component of the ACA. Also subsidies and marketplace or exchanges, right? So people can go on and purchase plans. All right, so the mandate. All U.S. citizens and legal residents are required to have qualifying coverage. We'll talk about what that means in just a second. If you don't have qualifying coverage, you have to pay a fine, right? So that you do it when you file your taxes. If you don't have coverage, you get assessed a fine. Yeah. This was gradually phased in. We also have the employer mandate, which is also called player pay. So large employers, if you have over 50 employees, you have to offer qualifying coverage to your employees or pay a fine, right? So this is designed to encourage employers not to just dump their employees onto the newly created marketplaces and exchanges, right? Because there are some benefits to employer-sponsored coverage, which is we won't go into today, but strengthening that system is a politically feasible way for us to maintain coverage level. All right, so when we talk about qualifying coverage, new plans that are to be ACA compliant, they have to cover these 10 essential health benefits, right? So if we look at this list, right, which ones of these are important to MCH populations? All of them, right? All right, so several of these are under threat through current bills that have been proposed in the Senate and in the House, right? So we've got to keep an eye on these, and we'll go through those in just a minute, right? So another major component of the ACA was the Medicaid expansion, right? And as designed, it would have covered every individual under 65 with incomes less than 138% of the federal poverty line. right? Why is it all individuals under 65?
Over 65, you're covered by Medicare.
Absolutely, right? So if you're over 65, Medicare kicks in, right? So does anybody know what the difference is between this kind of Medicaid coverage and the system we have now? Does Medicaid cover all individuals under 65 under the poverty level? No, not really, right? So as designed, it particularly covers women and children and the elderly and disabled, right? So this would have expanded Medicaid to, say, like childless adult males and things like that, right? All right, and so to encourage states to go ahead and expand, there was 100% funding for the first couple of years, declining to 90% starting in 2020 and moving forward. So that's also on the table now. And it included a higher match rate for Medicaid and CHIP, right? So Medicaid and CHIP are both jointly financed by the federal government and states. The federal government was going to kick in a higher percentage of those costs as part of this expansion. So subsidies. U.S. citizens and legal immigrants, if your income is less than 400% of the federal poverty line, you're eligible for subsidies. So those can be used to purchase healthcare coverage, right? So you can go on the marketplaces or exchange. The government's going to help you out a little bit with affording that care. Okay. So employees who are offered coverage are typically ineligible, right? That's because we also have this employer mandate, right? So that system kind of stays intact, and we don't want employers to dump their employees onto the exchange, right? So you also have premium credits, so helping people with the affordability of their care. So premiums are kind of your monthly or annually. You'll pay a certain amount, your premium for your coverage. And we're going to go ahead and help people out with that as well, right? Because some of these people may not have had coverage at all before because they just simply could not afford it, right? So this helps them out a little bit. If we say you're going to have to buy coverage, we'll at least give you some help. So there are caps at which you can't go higher than a certain percentage of your income in terms of spending for your premiums, right? And so those subsidies can be applied to plans that you purchase on the exchange or marketplaces. You'll hear them called both, but they're essentially the same thing. So the idea is that these would serve as clearinghouses for individual and small business coverage, right? So you can go on and it's like an Expedia or an Orbitz, right? And you can kind of choose which plan is right for you in terms of what you can afford, what kind of coverage that you want. They all include those essential health benefits, right? So that's kind of a floor that a plan can't go below. And so they're called the metal tiers, if you see that in the news, right? So the bronze plan being the lowest, and then you can move up to silver, gold, and platinum. And as you go up, they'll cost you more, but you'll also get more generous coverage. Right? Yeah, so they also had some rules that came in. You might be familiar with these. Guaranteed issue and renewability. So prior to the Affordable Care Act, there was no guarantee that you would be issued insurance coverage if you applied for it. The insurance companies could say, nope, we deem that you are too high of a risk and you're not insurable, right? And they also guarantee renewability. So prior to the ACA, you could have a plan and you could have something really bad happen to you health-wise and you could cost your insurer a whole bunch of money. And when it came time to renew your plan, they could say, sorry, we're not going to cover you for this next year, right? So the ACA puts in these provisions to kind of help protect consumers against those kinds of situations, right? Also, prior to the ACA, we had a thing called medical underwriting, right? So when you applied for your insurance coverage, you would fill out these lengthy questionnaires about your health history, any diagnoses you have, any medications that you currently take or have taken in the past, right? And the insurance company would get that from you, and they would look at your health history to decide how much of a risk you were to them, how much money they were likely going to have to pay out to cover you, right? And they could charge your premiums based on your health history, right? So sicker people are going to cost the insurance company more money, and so they would typically charge higher premiums to people who are sick, right, or had pre-existing conditions, right? So the Affordable Care Act gets rid of that. They can't do that medical underwriting. They can only set your premiums based on these limited things right here, right? And this is what we call community rating, which is pretty good, right? All right, yeah, sure.
What is family consumption? That's one of the criteria there.
Oh, family composition. Yeah, so
Read it wrong.
family consumption. We're not eating our families. No, that, it just has to do with the makeup of your family, you know, dependents and things like that. Yeah. All right, so how are we going to pay for this monstrosity? Oh, do we have another question? No, that's just an arm resting. All right, so how are we going to pay for this bill, right? So there are multiple ways that we were going to pay for it. Many of these have not been implemented, right? And so that's kind of one of the struggles that the ACA has faced in terms of being successfully implemented. Why is it difficult? Why might we kind of back off when it comes to enforcing these financing mechanisms? Think about it politically. Why is it easier to pass legislation on the protections and things like that than it is to enforce the financing of it?
Because your constituents are going to appreciate that you give them benefits.
Yep.
They're not going to appreciate you when you take more of that money.
That's right. People love when you give them stuff, but they don't like it when you take their money, right? A lot of these financing sources, right? So a Medicare payroll tax increase on incomes greater than $200,000, that's rich folks, right? And these rich folks vote, and they don't like more taxes on their income, right? A little bit controversial. Taxes on unearned income, so that's income from things like investments. Rich folks have those too, right? And they don't want to give up that money. We were also going to have an excise tax on Cadillac plans. You might have heard about that, right? So these Cadillac plans are the super duper fancy plans that employers were offering that are in essence too generous, right? Because we kind of want to shoot for the right level of coverage, but not an overly generous plan, right? So if you have a kind of what we would call an overly generous plan, a Cadillac plan at work, how might your behavior change in terms of seeking health care? That's right. You have a little sniffle and you say, well, I don't have copays, right? I'm going to go to the doctor, right? And so one of the main ways that we've been trying to curb healthcare costs, right, is to introduce these kind of cost sharing mechanisms, right? With the idea that you give people more skin in the game, right? You make them more responsible for a greater share of their healthcare costs and they'll use less, right? Because if I got to spend $25 to go get my sniffle checked out, I might think twice. Right. All right, and then we're also going to have fees on health insurance plans, right? Insurers didn't like that one bit. Pharmaceutical and medical device firms, right? Why, if you were a medical device or a pharmaceutical firm, why might you be opposed to fees? Profit margin, right? What's the kind of classic argument from pharmaceutical companies?
The cost of building new drugs is really high. Drugs fail in development.
Yeah, right. So the high cost of research and development for these drugs, right? So they say if you place these fees on us, we won't have as much money to direct into research and development. We won't be able to make these drugs that will be helpful for people, right? Some other sources, right? The favorite, the taxes on indoor tanning services, right? You're not supposed to do that anyway, right? So what were some of the issues? That's kind of it's much bigger than that, but we faced some issues. I don't know if you guys remember that or not. So political and business opposition. Does anybody remember some of the businesses that were just super upset about the individual mandate or the employer mandate rather? There were a couple really high profile businesses that were upset that they were going to have to give insurance to their employees. Anyone remember? You might have ordered pizza from them over the weekend. Papa John, he was so mad, right? It says, well, we're going to have to fire people. We're going to have to cut back down to part-time workers, right? So there's all kinds of business opposition to the employer mandate, right? So it was delayed. It didn't take effect when it was initially supposed to, right? When we roll out healthcare.gov, that's the government website that helps direct people on where to buy plans, right? I don't know if you all remembered, but the day it was supposed to go live, right, just kind of flopped. And it was very embarrassing for the people who were responsible. Right? But we got it fixed, but it left a bitter taste, right? So every state was supposed to create their own exchanges, right, on which people could go and browse for insurance products. So some states did that, some states did not, and ended up defaulting to a federal exchange, right? I believe Alabama uses a federal because why would they have their own? So anyway, so that kind of creates controversy later. We have less than optimal insurer participation on the exchanges, right? So we say everybody's got to go out and purchase insurance. And for those of you who aren't covered by your employer or a public option, you can go buy a plan on the exchange, right? So why would insurers kind of be hesitant about offering coverage through these exchanges? What kind of people theoretically would be signing up for that kind of coverage?
Lower socioeconomic status who might not have the best health.
Yeah, so lower kind of SES people. Yeah, people who don't have other options. What about their health status? Yeah, so they might have had poor health status and pre-existing conditions, right? So the insurers were kind of concerned that people with pre-existing conditions would kind of flood these exchanges, right? So what would happen to them if that were to occur? Yeah, right. No bueno, right, for the insurers. So, right, yeah, so the federal government comes in and says, don't worry, we're going to help you out. We're going to give you these subsidies to help cover these people, right? Those are now in question as well, right? So we'll talk about how if we get rid of subsidies, that might kind of crash the marketplaces. All right, so some states didn't expand Medicaid at all, and they have expanded at different times for those who did expand. Right, and then we delayed many of the funding sources, including the Cadillac tax, which hasn't come into effect yet. Right, so in addition to those kind of issues, we also had 2 Supreme Court rulings, right? So yeah.
Can you clarify a little more on the Cadillac tax? Is that taxing the people who are paying the premiums, or is it taxing the insurance companies who provide them?
Yeah, so it's like a tax on the employer, I believe, right? And so I think the employer and the employee would kind of face a joint.
So
I don't know.
they would just pay additional on top of the money they're already paying for the plan?
Yeah, the idea is to stop insurers from moving in that direction in the first place, right? So to kind of phase them out before this tax would come into effect.
Okay.
Yeah. So we've kind of had these 2 trends in private insurance that seem kind of conflicting, right? So we have some where we're going towards these very generous plans, but on the other hand, we also have a movement towards much less generous plans.
Well, because if you're able to afford a Cadillac tax, then I feel like, an extra $1,000 or whatever.
Yeah.
You're just gonna be like, okay, whatever.
It's a pretty hefty fine, I believe, but yeah, but you're right.
I mean, I don't know who pays that tax. Is that if you're the employee, you can obviously afford it, but I understand that they're taxing the insurance companies more.
Yeah.
Because you are providing it.
Yeah. So the goal is to get the employers to not offer those plans in the first place, right? But you're right. You bring up a good argument, right? So if I can afford this, why can't I have it, right? Absolutely. So twice the ACA was taken to the Supreme Court. In 2012 was the first ruling, right? And that upheld the ACA. So everybody's gonna. We were quite concerned that they would say, "Oh, the ACA is unconstitutional. The individual mandate, all of that stuff. You can't force people to go buy insurance." But they ruled that that was constitutional, but they ruled that the Medicaid expansion was not, right? So as written, it was a mandatory. Every state would expand Medicaid. And if you didn't expand, then all of your existing Medicaid funding would, from the federal government, would go away, right? The Supreme Court said that's not right. That's holding a gun to the head of these states. We have to make Medicaid expansion voluntary, right? So that was the first ruling. And the second in 2015, so there was language, right? You might recall that it said people would get subsidies for buying coverage on state-based exchanges, right? And so the lawyers figured this out. We're going to focus on those 2 words, right? State-based. So this went to the Supreme Court, but they ruled that Yeah, it's fine. We didn't, the language was just kind of, that's not literally what we meant, right? So people who buy their coverage on a federally run exchange plan, they're eligible for subsidies too, right? Because if we went strictly on the language, just those in states who had created an exchange would be eligible for those subsidies. And many states do not do that, right? So that would have really undermined the whole, right? So now to the good stuff, right? All the juicy things that have been happening post-election, right? So President Trump campaigns on repealing the Affordable Care Act, right? We're going to repeal and replace, or just repeal, or whatever, right? Whatever makes people happy. Right, so he's elected because Obamacare is failing and it's horrible, right? And so his election creates this mandate, right, to carry out campaign promises, right? So when you campaign on a certain platform and you're elected, that's an indication that the population is behind you, right? And they want these legislative changes that you campaigned on, right? So we come to an interesting situation, right? So he ran on repealing the Affordable Care Act. He wins through electoral votes, but loses the popular vote, right? So does that matter? Does his mandate to repeal the Affordable Care Act, does it carry as much gravity since he didn't win both? Or what do you guys think? I mean, yeah, my former students. Yes. Look smart.
Like the people who sort of support him are like super big Trump fans probably still want it repealed, even though he didn't necessarily win the popular vote, so maybe the entire country doesn't still want it.
Yeah, right. So maybe national polls say, well, a majority of people don't want it repealed. But he won the election, right? That's our system. He won by the Electoral College. He's the president. We're not all going to be happy. That's how it works, right? What's an argument on the other side? Yeah.
Well, I guess also looking not just at the presidential election, but also like congressional elections.
Yeah.
You know, he was going for and against the repeal.
Right. So great point. So we have the Republican president being voted into office, but we also have a switch back to Republican control of Congress, right? So both houses of Congress, right? So does that add a little bit more support behind efforts to repeal the Affordable Care Act? Probably, right?
And it'd be one thing if a candidate campaigned on one issue,
Mm-hmm.
and then you would know that if they, won the election, it's probably because, people want that one issue. But I would imagine there are a lot of people that voted for President Trump, not necessarily because of that issue, but maybe one or two others that were important to them. So it gets really complicated.
Yeah, right. So absolutely. We say this mandate comes from the election, but you're right. People campaign on multiple issues. So how do we know that people are voting based on healthcare, right? They might not care one bit. They might be more concerned about immigration or something like that, right? So why the big push right now? We see huge amounts of activity in the last 6 months, or however long it's been. 9 months since he was January. It's October. Yeah, about 9 months, right? He's gestated. Right. So why the big push? Sorry, throw it in there. So the Republicans have been promising to repeal and/or replace Obamacare for the last 7 years, right? So it's time to make good on their promise to the American people and get rid of this no good law, right? So after Trump is inaugurated, there's this process called budget reconciliation, right? So there's this window of time where Congress can pass bills or the Senate can pass bills with a simple majority, right? If it's a fiscal matter. So that was the big, so September 30th, so on Saturday, this past Saturday, that was the deadline. So that's why they were making these major pushes just over the last few months, right? So if it's a fiscal matter, they can pass a budget reconciliation. They only need 51 votes, right? With Vice President Pence serving as a tiebreaker if needed. Since that September 30th deadline has passed, they now need a majority or 60 votes in order to pass legislation, right? So all of a sudden it gets much harder, right? Because as we've seen, they can't even rustle up the simple majority, right? All right, so starting in March, we start with the House of Representatives, right? So oftentimes the House and the Senate will kind of examine similar measures concurrently. Then we do a bill reconciliation, right, where they kind of look and see what are the commonalities and how do we make a final bill, right, to go up for a vote. The House starts with Paul Ryan, right? He whips out his PowerPoint slides and he's real excited and he's going to school us all on how bad the Affordable Care Act is and how great his American Health Care Act is, right? So what changes would it make, right? It would essentially dismantle the Affordable Care Act, right? So individual and employer mandates are gone, right? You take away the penalty, that effectively takes away the mandate, right? Because if you're not going to do anything about people not having coverage, it's no longer a mandate, right? We eliminate subsidies, so people buying coverage on the exchange, not eligible for subsidies anymore. Instead, we could give you a tax credit, right? So that's kind of more of a conservative or Republican kind of minded way to go about doing things, right? And federal funding from the Medicaid expansion starting in 2020, right? So, you know, we'll have states may have much greater Medicaid roles than they did if they expanded Medicaid, but we're going to end that extra funding for them, right? So they're just stuck with a bunch more people after 2020. So this is the big one, right? Reform Medicaid with lump sum per capita enrollee payments, right? So the feds would decide on a certain amount that would be given to states, and it would be the same amount for every person in a state that is covered by Medicaid. As it is currently, Medicaid is fee for service, so if you are entitled to it, that is if you qualify based on your income or other life situations, you get Medicaid and they pay for whatever you need, right? So this would kind of essentially cap the amount that Medicaid could do for you, right? So you hit your limit, right? You might be out of luck. They establish a patient and state stability fund, right? This is kind of addressed at those people, those high risk people, right? So they can go on and some states have already done it. It's not a new idea, but you would create a high risk pool in states. So people who have high medical costs and are not really eligible for coverage or can't afford it by other means could have this one pool where they're in with a whole bunch of other sickies, but it would be subsidized by the government, right? To help insurers offset the cost of covering those people. We would expand allowable HSA contributions. So those are health savings accounts. So those are typically paired with higher deductible plans. For reasons we won't go into, they kind of end up being a tax haven for rich folks because they're the ones who can afford to contribute enough in their HSAs to cover their out-of-pocket costs, right? Topic for another day. And it would also, oh, sure.
Just one quick question about that reform Medicaid, the lump sum.
Mm-hmm.
Does that mean, the way you were describing it, it sounds like Medicaid will only pay up to a certain point for each enrollee, and then once they hit that point, there are no more services available? Or is it that the federal government will give the states a lump sum per enrollee?
The second. So it's not necessarily that you might lose once you hit, you're right, that was unclear, that you would lose once you hit a certain cap. But if you go over that, that just means less money for other people, right? So it wouldn't be like person one has $2,000 and person two has $2,000. But the federal government would give you one pot of money, but based on however many people are covered by Medicaid in your state, once that pot is gone, then you have to start making decisions.
The assumption that the only financing for that particular pot is the financing that comes from the federal government, or are states kicking in some money into that pot as well? Or
yeah, so states would be kicking in as well, under that scheme, under kind of similar arrangements that they have now, I believe. Yeah.
When Medicaid is currently, is there a cap at some point, or is it just never ending based on the needs of the people in a certain state?
Yeah. So there's requirements that the states come up with a certain percentage. So in a way, it's limited by state budgets, right? So the fiscal year budgets. But theoretically, no, there's not a cap on services, right? Which presents a huge problem, right? I'm not saying that we don't have to do something pretty smart about how we reform these programs, right? Because we cannot continue indefinitely under the current model, right? So anyway, It would also dismantle ACA taxes, right? So all those revenue streams, those would be gone. Didn't even make it to the floor for a vote, right? They pulled the bill because they didn't want to be embarrassed, right? Because if you're the Speaker of the House and you put your name on this bill, if you don't have enough support for it to pass before you even put it up for a vote, you kind of want to avoid that embarrassment, right? So that's what they did. And then the Senate says, well, we'll work on this, right? So led by Senate Majority Leader Mitch McConnell, right? Known for his ability to navigate Senate rules and come up with solutions, also known as Turtle Man. So anyway, there were multiple attempts by the Senate, so multiple bills that came forth. Some were repeal and replace, some were repeal only. We had the skinny bill, right? So first they try repeal and replace. They're not getting much traction on that. All right, so they say, well, we'll worry about replacing it later. We'll just go ahead and repeal it while we have this budget reconciliation in place. We only need 51 votes. Let's go ahead and get rid of it. Then we can work on the hard stuff, right? That didn't work either. You may have remembered on this third try, this Healthcare Freedom Act, killed by John McCain's dramatic no, where he walks up, right? Classic John McCain move. But also Senators Murkowski of Alaska and Collins of Maine, they've been pretty staunch opponents of efforts in the Senate over the last several months anyway, right? So they deserve credit. And it was those same group of senators that kind of ended up doing the Graham-Cassidy bill, which was just around last week. So none of these bills passed, right? They weren't voted on. So the Affordable Care Act is still the law of the land as of today. All right, we'll see what they do going forward. So I have some handouts, and you can go on the Kaiser Family Foundation website, and they have really great summaries of all these different bills and what they were trying to do. But they have a lot of commonalities. So these are some of those. They look very similar to the bill that was moving through the House, right? So we repeal the mandates, repeal the subsidies, but we would keep some of those market protections like guaranteed issue, community ratings, right? So not reverting back to medical underwriting. We still not allow people with pre-existing conditions to be denied coverage. People can stay on their parents' insurance up to age 26, right? Because we like these good parts, right? We can get behind these. And for the most part, we'd keep these essential health benefits, right? Though some were on the chopping block. Anybody remember what some of those might have been? There were news bites. Which of the essential benefits were most kind of contentious? We're going to get to a minute in case you don't get it.
Maternity coverage.
Yeah, maternity coverage, right? Oh, big deal. He said, I'm a man, right? Does anybody remember which one it was? Was it a senator? He said, I'm a man. I don't have a uterus. Why do I have to pay for maternity care? I'm like, I don't have a prostate. Just saying. But anyway, all right. So we'll go through which of those are kind of up for debate. All right, so we keep the marketplaces, but we would allow insurers to sell non-compliant plans off the marketplace, right? So those non-compliant plans, what they're talking about is kind of catastrophic coverage, which I had myself prior to the ACA, and they kind of stink. But if you are healthy, you know, they're an option, right? It covers you in case you're in a car wreck or something like that, right? But you don't get to go to the doctor for preventive care, essentially, right? All right, we'd eliminate the Medicaid expansion. We would convert to a per capita allotment. So some were per capita, some were proposals were for block grants, which would be slightly different. So a block grant is where the federal and state money that is spent on Medicaid would be looked at, and they'd come up with a formula, and each state would get one big block sum of money. So regardless of how many people you have covered under your Medicaid, you get your block, and then you get to decide what you want to do with it, right? What's kind of the conservative appeal of a block grant? Does anybody know? What is the kind of classic argument for block granting? Yep. Yeah, right. Autonomy to the states. We let states do what they want, right? States know their people best, right? So that's kind of a classic conservative move, right? So we might see some sort of that showing up soon, right? We're going to add this state option to require work as a condition of eligibility for Medicaid, right? So if you're non-elderly, not disabled, and not pregnant, and you're of working age, states could theoretically require that you work, right, in order to receive Medicaid benefits, right? We're going to stop funding for Planned Parenthood for 1 year, all right? That's just a political move. That's not really. Yeah, right. Nobody likes Planned Parenthood. Right. We're going to encourage the use of these health savings accounts, right? Because people know how to spend their money best, right? Is the argument. All right. So in essence, you're just increasing the amount that people can sock away in their health savings account tax-free. Which that money can also be invested, by the way. So we would eliminate the Prevention and Public Health Fund. So this was a big fund that was set up by the Affordable Care Act, directed more towards kind of public health activities, disease prevention kinds of things. So get rid of that. They included, right, because this is, right, we all know that the substance abuse issue is becoming a really hot topic issue. So they throw in this block grant for states that they can use for addressing the substance use disorder. So treatment and prevention programs, create the high-risk pools again, state design healthcare reform, things like that, right? And they would repeal most or all of the Affordable Care Act revenue provisions, right? So all of those means that were designed to raise money to pay for the ACA, those would be gone. All right, so we've got to mention Bernie, right? Not going to happen. Just hate to let you know, at least anytime soon. But he did throw out his Medicare for All Act, all right, which kind of sounds like a dream a little bit, especially if you're sick. So this is Bernie Sanders of Vermont, who you might recall was in the running on the Democratic ticket, primarily. So all U.S. residents would get free health care. There would be rainbows and sunshine for everyone. Only public or nonprofit institutions could offer coverage. So right now we have for-profit insurance companies. They would not be allowed to participate and offer coverage, right? But all of their employees and things like that could be rejobbed or removed. What is the transferred, right? We could fold them into these public or nonprofit institutions, and they could still essentially do their jobs, but they couldn't be for-profit companies, right? So this covers basic medically necessary care, but insurers could sell additional policies for things like cosmetic surgery and some of those other kind of non-medically necessary things if they wanted to, right? So if you're rich and you can pay for your boob job, we will let you do that, right? So they can't have financial incentives based on utilization, right? So a lot of times in trying to control cost, what insurers will do is to kind of try to reduce utilization, right? So things like health management organizations and accountable care, right? They kind of decide what can be covered or not and keep a tamp down on utilization. We'd have a national board of universal quality and access, which Monica would work for. And they would assess quality, access, and affordability, right? And we'd integrate the Indian Health Service because they're struggling. All right, so that sounds pretty good. But alas, we have our history of incrementalism. I don't see this happening anytime soon, but it's fun to think about. So really, the kind of fun stuff, and I hope this is where we get a little bit more interactive because I'm getting tired of talking. So these reform efforts, right? It gets kind of exhausting trying to keep up with everything that's flying around, all the different proposals. But we have to remember that these are actual people, right? And these changes can have really serious effects on people's lives. What happens if we get rid of the protections for people with pre-existing conditions again, right? At minimum, their premiums probably skyrocket, right? We're not talking about just people with diabetes, cancer, heart disease, right? I have kidney stones, and that's a pre-existing condition, right? If you have depression, if anything is on your medical record, it could probably count as a pre-existing condition, right? To put it in context, 1/3 of Alabamians have pre-existing conditions, right? So this is a lot of people. This is not just the really sick people, right? They've talked, like we were just talking about getting rid of the mandated coverage of the essential health benefits, right? So there have been talk about getting rid of the mental health parity laws, right? So mental health has to be covered to the same extent that physical health ailments are under current law. They say, well, we can get rid of that, right? It's not as important, right? The maternity care, like we were just talking about. So pretty huge implications, right? As under the ACA, there's a prohibition of annual and lifetime limits. So prior to the ACA, there were sometimes these annual or lifetime limits in place. If you had some catastrophic disease that you were diagnosed with, you might hit your annual limit, and your insurer would say, well, you've cost too much, right? You got to start paying now. We're done covering, right? And you could also have lifetime limits. So imagine a very premature baby born, right? 23, 24 weekers. Think of the money, the millions of dollars probably over the course of their lifetime that they'll use, right, in terms of medical care. What about those kiddos, right? The Medicaid expansion is probably kind of the biggest thing to watch for is Medicaid, right? So threats of the reduced matching rate, so that's the FMAP is the federal rate. So making states more responsible for a greater percentage of financing, right? How many states do you know that can afford that? Right? Yeah, not Alabama, right? Maybe Massachusetts? Yeah, right. So Alabama could be screwed, right? And other poor states. Per capita caps, right? So as we were just talking about, once that money is gone, what are we going to do? Right? The majority of Medicaid costs go to elderly and disabled, right? So we think of children and mothers, but what about grandpa who needs to be in a nursing home, right? What are we going to do when we run out of money to cover those people, right? It's pretty serious. Even if you're not on Medicaid, I am sure that you all know people who are affected by this, right? Even if you don't realize it. So pretty serious. And block granting, so giving a set amount of money to states, block granting not based on individual enrollment, and they just say, here's your lump sum of money. So states that expand in Medicaid, they have much greater numbers of people on their Medicaid rolls now. In essence, this could kind of punish those states, right? So there's some political maneuvering there, right, to kind of punish these states that expanded Medicaid. So what kinds of states expanded Medicaid, typically? Yeah, right, so left-leaning states, right? These are parts of conservative efforts, right? So there is some, like, well, these states who held out, like Alabama, are kind of sitting around going like, yeah, that was the plan all along, right? Who knows, right? So another threat, and I think kind of the most likely scenario is that we'll see this kind of continued undermining of the Affordable Care Act. So I don't know if you'll remember, but when Trump came into office, he immediately told the IRS, look, you don't have to be so stringent on enforcing the penalties for the mandates, right? So there's all kinds of ways that we can non-legislatively undermine this law, right? We don't have to wait for a full repeal. We can kind of wait for it to implode, right? As Trump is fond of saying, right? So funding for navigator groups, the Affordable Care Act created these groups of people. They would get grants, so they're in all different states, and they would help people find coverage that was right for them, right? So you could go to these groups and they would tell you whether or not you qualified for CHIP or Medicaid, or what individual marketplace plan looked best for your family, right? So sometimes the funding has been cut like up to 90% for those grants, right? So are there public health, fairness, equity concerns that arise because of those cuts to these navigator groups?
Navigator groups are typically going on in communities that are low SES and low healthcare access.
Yeah, right. So these facilitator groups are kind of primarily aiming to help these groups who really have trouble navigating the system, right? So these people who are already kind of marginalized, right? So poorer groups, racial minorities, immigrants, right? We're seeing a big effect in states where there's high immigrant populations, right? Because if you're new to the country, you don't know what's going on, right? How are you supposed to figure out what to do, right? So pretty significant. Advertising for the Affordable Care Act was cut by 90%. since Trump has taken office, right? So that might cause not as many people to try to sign up as would before. The enrollment period, so the time of the year where you can sign up for a new plan, that's been shortened. So that gives you less of a window of time to kind of sift through all the plans and decide what's right for you. All right, so.
Scheduled maintenance on the website every Sunday.
Oh, what, schedule maintenance every Sunday on the website? Okay. Oh, a little time. Yeah. Also the day of the week where people are most likely to be off of work. Clever. Anyway, right. So these are kinds of the things that we need to keep an eye on, right, in terms of protecting our vulnerable populations. So the point, I would say that there are more humane ways to go about this, right? We're not saying that it doesn't need to happen. Obviously, it does, right? Something has gone horribly wrong in our healthcare system, and we have to do something about it. But this is probably not the way to go about it, right? This kind of rushed, partisan, hyper-partisan legislation, probably not the way to do it, right? And there's lots of people who have pretty good ideas about how we could reform it out there, right? So we're just waiting for someone to ask. All right, so where do we go from here? Clearly, we desperately need health reform. The ACA, in my opinion, right, is a step in the right direction, right? We have a lot fewer people who are uninsured, and that's important, right? Particularly because they were kind of typically more marginalized populations who are uninsured, right? But just getting people coverage, that's not enough, right? That doesn't, just giving people insurance doesn't solve the problem of high spending and poor outcomes, right? It's about a fifth of our economy. In my opinion, we need to take our time. We need to slow down and really think about the implications for different things, right? So it's not just insurance coverage, right? It's hospitals, right? So what happens to hospitals and rural health providers and things like that if Medicaid is cut by a ton, right? And that's a problem. They would prefer to have people with insurance coverage coming in their doors. And this is kind of the argument that John McCain, right, is kind of making, is that it's not necessarily that I disagree with all of the components of these bills, but the way we're going about it is not right. You know, we haven't taken enough consideration of what's going on, right? We feel powerless maybe sometimes as constituents, but it's our job to keep an eye on these folks, right? We elected them, so we have to keep an eye on what they're doing, and it's our job to you know, demand that the things that we care about are taken seriously, right? And so we need public health, right? Throw in a cookie for public health, right? So we need systemic changes. What do you guys think? How are public health people kind of poised to address this issue in a way that is different from other kind of interest groups when it comes to healthcare? Yeah.
I think we often provide the angle of the more primary care and then preventative care aspect of things people don't consider with healthcare issues.
Yeah, so primary and preventative care. So kind of seeing the big picture maybe.
And also that's often the more affordable option in a lot of cases too.
Yeah, so a lot of times legislation and other kind of policy changes come about as a reaction rather than being proactive about solving problems. And sometimes you get in most times probably you get in a crunch and you're not able to see that long-term goal. But I think as public health people, we're kind of more suited to seeing those kinds of things, right? The role of non-medical factors in health, right? So clearly just pouring more money into it is not going to solve the problem. What are we talking about when we talk about non-medical factors? What's kind of unique about America that might be driving our healthcare costs that is not disease-based?
A third of people are obese and another third of people are overweight.
Yeah, so obesity. What about totally non-medical? Yeah, immigration, right? So we've got those issues. We've said it several times. Poverty, right? Low SES, crime rates, gun violence, homicide rates. So we have a lot of unique challenges that public health is more poised to address, I believe, than just from a purely medical perspective.
As a foreigner, the fundamental approach to healthcare, just that it's more as an individual kind of thing.
Yeah, right. So we move from the individual healthcare level to a broader public healthcare level, right? Yeah.
Health insurance is possible in other countries.
Right.
So,
Right. So insurance is maybe one component, but maybe it's also improving our education systems. Maybe it's improving economic opportunities for people, right? Maybe it's cleaning up environment so people don't have to live in lead-laden homes, right, in poor areas of our community. Okay. So last I'll throw out here, I think we need to be better at advocacy. We need to really learn how to walk the line between research and advocacy. There are groups out there that are willing to help us, right? To kind of learn the kind of legal ins and outs of what's lobbying and what isn't, and how we can influence things in a way that doesn't interfere with some of our professional obligations, right? So we have to understand how policymakers think. We have to be able to sell things to people and make convincing arguments, right? Because I think we can face the fact that our voice is probably one of the puniest when it comes to these healthcare reform debates, right? We don't have a lot of money or lobbying capacity. Right. So anyway, any questions, comments? I'm sorry, I went the whole time. Thanks for staring at me for an hour. I appreciate it.
I have one question, Katie. So
Sure.
because these things are changing so constantly, what's a good source for students or people who aren't as connected in the policy world to keep up with, valid resources?
I like the Kaiser Family Foundation a lot. I usually do like Reuters for just kind of regular news. The BBC is pretty good, right? Because they're removed from the partisan American news. Yeah, because there is that lag in the literature, so it's hard to find. But professional organizations, things like, like the Organization for State Health Policy, Academy Health, APHA, those places are pretty good places to find briefings.
Great.
Yeah.
Thanks so much. Thanks everybody for coming. Don't forget, if you want to donate to the Halloween Bake Sale, you can talk to me afterward. It's on October 31st, and you'll have a great afternoon.